now like to welcome one of our keynote speakers, Dr. Peter Karachunsky. Dr. Karachunsky is a board-certified neurologist with special qualification in pediatric neurology. He specializes in neuromuscular medicine. Dr. Karachunsky is an associate professor at the University of Minnesota, the clinical director of the Paul and Sheila Wellstone Muscular Dystrophy Center, and the director of the Neuromuscular Pathology Laboratory. He treats adult and pediatric patients with a variety of neuromuscular diseases, including muscular dystrophies and related disorders, spinal muscular atrophies, hereditary polyneuropathies, myasthenia gravis, and myositis. I've had the privilege over the last few months to work with Dr. Karachunsky and his team planning today's symposium, so we really appreciate him chairing this event, and I'll turn the time over to him.
Well, good morning. Good morning, everyone. Welcome to this symposium. It's been really nice to be back in person. I think the last time it was probably for this symposium to happen was prior to pandemic, and it's our second actually event in person because we did have a lab day in the spring at the MD Center. So it's nice to get back to this routine to meet in person, and I welcome everyone. And I want to say thank you to MDA for giving us privilege to host this symposium. So, and I realized that when you talk to people with a variety of impacts from different neuromuscular disease, it's hard to find a topic that would be interest for everyone. So I try to think about this as any progress we make in any single disease is impacting the entire field of neuromuscular medicine. So I want to specifically talk about importance of early diagnosis. Even so, I feel like I'm preaching to the choir here, but I do want to highlight a few things and demonstrate what difference it made for neuromuscular community. So I want to start with this slide and just tell you and what unprecedented time we live. It sounds like cliche, but that's true. We see a lot of new treatments that are approved by FDA to treat neuromuscular disorders. So there are more than 20 disorders that been treatments approved over the course of last 30 years and especially the last 10 years. So which is great and also gives us a lot of feedback about what we should do better. And so one of the latest news was that in August, RASP, which is National Committee for Newborn Screening that meets a couple of times per year to discuss various, mainly pediatric diseases, to see whether there are ready to be in newborn screening. So, and of course, Duchenne muscular dystrophy has been a disorder that is on their radar for a very long time, but only now this committee thinks that it's ready to for discussion about newborn screening. So it means that we are getting close to very early diagnosis in this disease, and I want to next give you a little bit overview background about how we do make diagnosis and why what we're doing right now is not adequate for most diseases in terms of diagnosis. So let me play this very typical story So the point is that a very typical story that parents of usually young boy become aware of something going on based on somebody telling them. Even so, they may suspect it long enough that something is not right. So, so how we make a diagnosis? So that's one of the ways that patients get to our clinic is they develop symptoms, and then as a neurologist, we use approach of clinical evaluation, and we look at what we call pattern recognition, and we analyzed all the clinical symptoms and findings on examination and the distribution of muscle weakness, and then we quite often use additional tests that we need to make a diagnosis. And
throw baseball with them, play football, and go out golfing. That all changes.
His preschool teachers pulled Tim and I aside at a conference and said, Amber and Tim, we think something might be going on with Austin physically. He doesn't seem to be moving as well as other kids his age.
He would waddle instead of walk or run. He just had a little funny gait to him. And he never was able to fully walk upstairs. It was always crawling upstairs.
Austin has very enlarged calf muscles, and that is a main sign of Duchenne.
His speech development was delayed, and all this time we always thought he's going to catch up with his other kids. He's just developing slower than our kids. Checking CK levels can be a quick indicator of, the diagnosis for muscular dystrophy.
so the question is it early enough to make a diagnosis at this age? So, so as I mentioned, we use different tools, and the way the diagnosis can be made is a clinical evaluation. Sometimes we have an opportunity with family history, but this can happen only to a few patients. Sometimes incidental finding can lead to relatively early diagnosis, but again, it's very random and inconsistent. And then there are screening procedures, and those procedures can be really a game changer, changers for early diagnosis. So, as I mentioned, pattern recognition is a very common approach for a neurologist, and we've always been proud to be first to recognize it and make a correct diagnosis. And you can see different muscle diseases, as an example, have different patterns of presentation, muscle involvement. The highlighted muscles are the ones that weaken these particular disorders, as you can see. Let me go back just to highlight that the first person who recognized the pattern was Duchenne, and he made phenomenal observations and provided a detailed description of the first cohort of patients that he collected and recognized common pattern in those patients. It took another 100 years for Dr. Becker, who recognized similar pattern but in older patients, and this condition was called Becker muscular dystrophy. And he also demonstrated that this condition, as well as Duchenne, are linked to X chromosome and was mainly occurring in males. Not till 1986, when DMD gene was mapped and then sequenced, really understanding came about that essentially it is the same condition, that is just a spectrum of manifestation of the same disorder that is caused by abnormality in the gene dystrophin. So now we are able to pinpoint exactly the underlying genetic condition. That allows also to, knowing what the genetic diagnosis is, allows us to do diagnose based on the family history. And obvious pros that, those patients, individuals can get a very early diagnosis. But what good does it do, right? And then genetic counseling and family can help planning. That's a very big advantage. And severely affected individuals sometimes can trigger diagnostic workup in some other family members and discover the entire family tree that there are some individuals who are affected as well. Of course, what is not sufficient about this that not all genetic disorders have family history. In many patients, this happens randomly, and they are the only ones in the family. And it only can be helpful for fractions. So still, a lot of patients would not have an early diagnosis just because of the family history. There was a study about almost 10 years, actually exactly 10 years ago, 2013 it was published. It was led by Dr. Connolly, and we also were part of this study, when we looked at the relatively small cohort of very young boys at the age of starting at 1 month to 3 years. And the reason this age group was chosen because most of boys who are diagnosed with Duchenne muscular dystrophy are between the age of 4 and 5 and sometimes later. So, and the idea was one, to see whether we can identify any manifestation of this disease, and can we use this information to further use for clinical trials and monitoring. So it turned out that actually these boys were quite different from their average peers. And they had significant motor delays, and the effect of so they used the different scales to assess that, but the bottom line is that the effect of the disease was quite evident in even early age. Even so, as you can see on this graph on the bottom, that the boys continue to show gain of motor skills, but when it's compared to average boy of their age, it was quite delayed. So we kind of knew that, but being able to demonstrate it in a systematic fashion was very useful information. Now you can see that, in this study, the curve is average, so in the spectrum of normal, and the boys in the study bars, the gray bars, they're shifted to the left. It means that they're delayed. So you can see in many aspects, including cognitive language and especially motor function. Now, if you looked at an average that times it takes for diagnosis to happen, that an average first symptoms recognized, at least by caregiver or someone around the child, is 32.5 months, and the first presentation to a health professional 10 months later. So it tells you that there's not enough knowledge about this to pursue it in more sort of rapid fashion. But if you look at the biopsy of an individual patient who, at the age of 3, you can see in comparison with the healthy control on the left, on the right, how much disease burden is already present at this age. So by looking at just this picture, one can't think of this as to be an early diagnosis, even at the age of 3. So the answer is, how can we make a diagnosis really early? And of course, we recognize all the stages, and the question is whether treatments that we already have for this particular condition, and now there are 6 approved, FDA-approved treatments available, whether they're going to have an adequate impact on delaying progression of this disease. I'm going to shift gears, and I'm going to mention about another disorder, which is not a pediatric one. It is ALS. But the idea of early diagnosis is very critical in this disease, especially. It is very rapidly progressive. And it turns out that because of recognition of some forms of ALS being genetic, caused by a specific genetic disorder, one can identify, again, based on the family history, that these patients are at risk of developing ALS. And what scientists decided to do is to find a specific marker that can be identified in this disease and be correlated with the state of the disease. It turns out that the individuals, even in pre-symptomatic phase, when they don't have any complaints and doing just fine, have already changes in their markers. And you can see these 3 lines, they're just indicating different pace of progression, but the idea is the same, that in this, I don't have a pointer, but in this, the first gray bar. Sorry? Yeah, I don't see. On microphone? Okay. So, but you can see that the rise in this curves show change in the biomarkers already. And then there is a very short phase when there is a conversion to a symptom onset. And there is still, but very gradual increase in markers. And then when the diagnosis is established or symptoms are established, it's actually essentially stable. So it tells us that the disease actually starts way earlier than we see symptoms. And the question is, can we actually intervene early enough to prevent development or at least delay development of symptoms? And sure enough, there is a study, again, just recently approved medication for treatment of ALS caused by a gene which is called SOD1. It's a minority of patients, but still very informative study that shows response to treatment fairly rapidly. And you see that the red line is the one that cohort of patients who had treatment. So, and now there's a study underway that is looking specifically at pre-symptomatic patients and whether intervention in pre-symptomatic phase can actually avert or delay onset of the symptoms, as the symptoms typically start within 6 to 12 months of starting to see elevation in the neurofilament light chain biomarker. So what are screening approaches we're using to make early diagnosis? Obviously, newborn screening. We can do parental screening, but parental screening is not going to involve the entire population. So it's going to be, again, few people would be getting checked for this. Prenatal screening, that's while mother is pregnant. So that's may be useful, but again, it's hard to implement it uniformly. Familial screening, again, based on the family history. And the other approach would be biomarker screening. As I mentioned, neurofilament for some neuropathic disorders, CK level can be used for myopathic diseases, muscle diseases. Now I want to share the experience that we have with early diagnosis in spinal muscular atrophy. Just a very brief description of this disease. So it's a disease of the motor neuron that connects to the muscle, and when the neuron doesn't do well, the muscle doesn't do well as well. And you can see in this particular picture that the child is profoundly affected, and even without video, it's clear that it's not doing well. So if you look at this picture, so you can see that the tiny nerves are motor nerves, and as a control, thank you. And as a control, these are sensory nerves. So spinal muscular atrophy is a pure motor disease, so it affects only motor function. So you can see how wasted these nerves are. And as a result, we see very significant atrophy in the muscle as well. So in mid-90s, the gene was discovered that caused the SMA. It's called SMN1. Also, shortly after was gene discovered SMN2. They are very similar, but SMN1 can make protein which is called SMN1, and all healthy individuals have at least one copy of SMN1. Affected individuals don't have SMN1, and therefore they're not able to produce any protein, but they have SMN2. And SMN2 can make a little bit of SMN1 protein, full functional protein. Okay, so, and some individuals with spinal muscular atrophy would have not one but multiple copies of SMN2. And it turns out that it does change the severity of the disease. So you can see that I'm showing this table that the severity of this disease can vary from quite severe type 1, intermediate type 2, and very severe type 3. And there are some, gradation. It tells you that it's actually a spectrum. It's not just type 1, type 2, and 3. So, and of course, now we have a growing population of patients, what we call pre-symptomatic, and quite often we may not even know what exact type they might have. And I'll show you why. So, apart from three treatments that are now available for treatment of spinal muscular atrophy, another major breakthrough happened that it was established in newborn screening. So the newborn screening, just give you a little background what it is, was actually started in 1960s, and it was specifically designed for a condition which is called phenylketonuria. And in Minnesota, it started in 1964. The idea of this is that if you just modify the diet of these individuals, you can actually prevent development of progressive mental retardation in these children. So, which is has been a very successful program. And after that, there are now more than 60 disorders that are screened by newborn screening, and now including 2 neuromuscular disorders, which is Pompe disease and spinal muscular atrophy. Newborn screening for SMA began in March 1st, 2018 in Minnesota. And we were actually the first state in the United States to start screening. And now there is 99% of infants born in the United States are screened. And the reason is it took a while because every state has to go through their own procedures to approve the newborn screening and organized. So newborn screening is a public policy, and it takes time for some places to get in place. So in Minnesota, so this data for Minnesota only, over the course of first 4 years of screening, we identified 24 infants, and they are all were true positive, and there are no negative, false positive, I mean. And there are, as far as we know, we didn't see any missing diagnosis. So it's very specific and very sensitive technology that allows us to do this because it's based on a genetic test. So, now, now in terms of presentation of this patient, majority of patients actually, when they're born, as you may all know, they're first seen by care team that deliver the baby, and they look at them, and they're examined by a pediatrician on the first day or two, and they report the baby is normal. And almost every single, maybe just one that was born were presumed to be healthy, normal newborns. So you don't see any symptoms. Now, if they come to a neuromuscular clinic, then we able to have a trained eye and some other techniques to identify some symptoms in these patients. And you can see one symptom is we've seen in 5 patients, 2 in 1, and 3 in 2 patients. So it's really hard to recognize for anyone and make a diagnosis right at birth. So I mentioned there are 3 treatments available. The first treatment was nusinersen was approved in 2016, and then gene therapy was approved in 2018, and risdiplam was approved, I believe, in 2019. They all work well, and I'm not here to really comment on specific treatments and the differences. In a broad sense, all the treatment effects are comparable, but we actually don't know that for sure because no one studied that. So before I show you the results of that, I want to show you that if you look at the very severe disease of spinal muscular atrophy, but trajectory of their symptoms and effect on their function is very predictable. And we know that by age of, and the way how it's described as event-free survival, what it means that without any medical care or intervention, this patient would not survive behind this particular time frame age. So let's say if we didn't do any feeding tubes, if we didn't do any respiratory support, these patients would not survive. So by age 8 months, you would see 25% of babies not surviving, and so forth. By the age of 2 years, almost all patients survive. And not to say that the effect on their function is tremendous, and so it's fairly predictable. So, and we know that majority of patients who have only 2 copies of SMN2 gene would likely have type 1, which is most severe form. So this one is the cohort of patients who were pre-symptomatic, means that when they were diagnosed, they didn't have any symptoms, didn't have any findings. So they're predicted to have severe form of SMA, and we would predict that majority of these infants would not live beyond second birthday. So now we see the results here, and you can see that you can see the motor milestones and for all these patients, and you can see that majority of them actually not only were able to acquire this milestone, but they acquired them actually like an average infant. Some of them still have trouble telling us that even when they're pre-symptomatic, there is a significant disease burden that is affecting them. We're just not able to identify because, of course, as you know, a baby's function is limited. They don't do as much. And and here you see as well that these are pre-symptomatic patients. And I'm sorry, this one actually had some symptoms. But dramatic response. And then we have this slide that shows actually effect of gene therapy. And you see essentially similar effect that a lot of infants show remarkable improvement and continue to show normal development. If you see, here's the blue line, all patients survived 100% comparing to control group right here. So these are criteria that are used for newborn screening, and one is to have an established natural history marked by significant burden of the disease. We have a target population, positive screening results, and screening platform is robust, reproducible, and affordable. So that was exactly constellation available for spinal muscular atrophy to be approved by newborn screening, and actually results exceeded all expectations. I think there are going to be more and more neuromuscular diseases that would fit this, and even newborn screening is designed for pediatric population. There are going to be probably some ways we can screen adult patients as well in the future. So I just want to show you that our anecdotal experience with our patients who come to our clinic. So this infant, toddler now, obviously, is walking like a normal toddler with 2 copies of SMN2. So it's really, so this child would be predicted to have likely type 1 spinal muscular atrophy. Another example I want to give you is actually siblings with 3 copies of SMN2. So one sibling was diagnosed with newborn screening, and another sibling was diagnosed because of the younger sibling was diagnosed. And so it was a late diagnosis. So, you can see, and both are on treatments for, and younger one received gene therapy, and the older one is still on treatment with another medication because he was older and was not eligible for. So you can see the difference between the child who received. Good job, guys. Who received treatment right at birth, essentially within first month of life, and the child who is actually doing well but already lost, and that unfortunately is not coming back. The other thing that newborn screening allows us to do is to better understand the natural history of the disease. And in the past, when we had to diagnose spinal muscular atrophy by traditional way, we always thought that first they have low muscle tone, weakness, and then they develop problems with swollen and not being able to take in enough nutrition or having high risk of aspiration. Now we've actually studied our patients with predicted SMA type 1, and so that was done by our speech therapist, Kathleen McGrattan, who found that actually pre-symptomatic patients, as well as symptomatic, but especially pre-symptomatic, would actually have abnormalities in their ability to swallow. So what does it tell us? That even when they're born, the effect of the disease is evident, and we now recognize that the disease begins even before the babies are born, and certainly that potentially could have some implication in the future for our treatment approaches. So, so these are obviously benefits of early treatment. And while now we are talking mainly about pediatric disease, I think it's relevant for all neuromuscular diseases as we get more knowledge and be able to better understand pathophysiology disease, recognizing specific markers that would allow us to do very early diagnosis. I think we will get to a much better place to intervene. So I think that's it.